Hello, everybody. I'm Dr. Saundra. I'm at the University of South Florida, and I'm going to be talking to you about the update on the treatment of pediatric non-OCD anxiety disorders. So in terms of I'm just going to kind of do an overview. I think the last time we did this was 2018. So I kind of looked at the literature to kind of see what has been published in terms of anxiety treatment since 2018. And really, if you look at the literature, I think that cognitive behavioral therapy is still considered kind of the gold standard or the go-to when possible as kind of the standard of care for treating anxiety disorders. There have been a variety of articles published about various stepped care models where people use either print manuals for families to use at home, or whether it was one that was a CD-ROM, one that was and some that were online modules. Typically where the family is given assignments and works works on their own at home with maybe once a month phone call from a therapist to kind of check in and see how do they think things are going, implementing what they're finding, in the educational materials. And so a variety of, there's been 3 or 4 different studies published in the last couple of years that all showing that there is improvement in about 30 to usually around 30% of the sample will improve doing the less intensive or less office-based treatments, which allows, obviously some access to care issues to be addressed in terms of families that either can't get cognitive behavioral therapy in their area or just flatly can't get in touch with therapists or don't have transportation to get to therapists. So that allows, at least 30% of people to improve. And then, usually at some set point, they may transition into, face-to-face if they're not responding. So there's a variety of articles about that. There was an article comparing cognitive behavioral therapy and ACT, which acceptance and commitment therapy, which found that those were both superior, both versions were superior to a wait list. Similarly, there was a study comparing cognitive behavioral therapy to psychodynamic treatment for anxiety. And again, both were superior to a wait list. And then there was a treatment where they treated just the parents. There was no treatment to the child, just delivering parent strategies. Those were for kids ages 7 to 14, and they found that to be non-inferior to cognitive behavioral therapy. There's a similar study in parents, giving the parents information about anxiety treatment for kids ages 3 to 5, which I think that's a little less surprising that would have worked, but this was actually when kids ages 7 to 14. So there's a variety of comparisons of what else you could do other than cognitive behavioral therapy. If for some reason that's not a good fit for the family. There's also been some cognitive or attentional bias training for social anxiety about what people are paying attention to. And there's actually been a few studies looking at virtual social skills training for anxiety disorders. So some studies, but I think overall we would still be recommending cognitive behavioral therapy as the thing that people should start, to try to look for and then modify, as needed. In terms of new publications or treatments related to medication for anxiety, I really didn't find very much at all in the last 4 years. There's been no new medications approved since we last met and talked about this. There was a study with generalized anxiety disorder using escitalopram in youth ages 12 to 17. It wasn't a really large study. There was a total of 51 patients in that study. It was an 8-week trial. It was a forced titration model where they started on 5 milligrams for 2 days, went to 10 milligrams for 7 days, and then up to 15 milligrams. They could be increased further to 20 milligrams either at week 4 or week 6 of the trial. The PARS was one of the primary outcome measures and some of the CGI scales. And at the end of the study, they saw a CGI response in 62% of the patients taking escitalopram and 24% of the patients with placebo, yielding a number needed to treat of 3. So this is pretty similar to what we've seen with other SSRIs or other medication treatments for generalized anxiety disorders, that there's pretty low placebo response rates as compared to the challenge we have in depression studies where we get a high placebo response rate in kids and around 60% of people responding to the medication. So that's kind of what I could tell you as far as I think what was new in terms of anxiety treatment. mean, there's lots of different things out there, but in terms of just updating these guidelines, keeping in mind our audience, being a lot of primary care doctors, general psychiatrists, just kind of looking at what are the things that what kind of studies would influence our recommendations. So, and so if we look at the anxiety disorders in children for under age 6, I would not recommend any changes. Level 0, a comprehensive assessment, including a history of stressors, trauma, parental anxiety, and observation of parent and child interactions. Level 1, start with a psychotherapy for at least 12 weeks that includes the parent and has some exposure-based cognitive behavioral therapy, that's been kind of adapted towards young children. Level 2, if there's poor or partial response to psychosocial treatments after 12 weeks, consider combining the treatment with fluoxetine with the concurrent psychotherapy for children ages 4 to 5. So that kids aged 4 to 5 could have the option of taking fluoxetine. And then level 3, if fluoxetine is not successful, consider sertraline in combination with the psychotherapy, and start low, go slow, monitor closely. And I think what we talked about at last time was really that there's not a lot of studies under age 6 or 7 at all. And I think this recommendation for fluoxetine came out of like the small study with kids with selective mutism. I think there's like 11 kids in that study. So really not large N's for us to make a clear recommendation about one SSRI or another, but we had last time picked fluoxetine, then sertraline. I think that would be fine. So we said not recommended for kids under age 6 was the use of medicine without psychosocial treatments. We did not recommend the use of tricyclic antidepressants or alpha-2 agonists. We could clearly talk about if we want to include alpha-2 agonists here. I think really there's just not a lot of data looking at alpha-2 agonists for anxiety disorders, period, and certainly not in this age group. But I will say that it seems as if in clinical practice, a lot of people are more comfortable giving alpha-2s to children than, let's say, stimulants or SSRIs. So we could debate if we want to just remove alpha agonists from this statement or leave it there. We don't have to recommend it, but we don't have to caution against it. I don't know if there's really data to say one way or the other. Ongoing use of benzodiazepines is not recommended. We say they can be used short-term for severe anxiety with medical or dental procedures, and just that there should be caution in prescribing for under age 6 at all. And then for dosing, we refer to the table. So that's under 6. Looking at children older, children ages 6 to 17, level 0 is a comprehensive assessment, including evaluation of risk factors, family coping skills, comorbid conditions, and the severity of symptoms, both psychiatric and medical symptoms. Level 1, if there's a mild or moderate anxiety disorder, 1A, provide the family with psychoeducation about anxiety disorders, and we recommend trying to start with cognitive behavioral therapy, including some level of exposures in the CBT. 1B, if the CBT is not available, consider an evidence-based psychosocial intervention or an online web-based therapy. So for instance, if you've got a kid with, a young kid, a 6 or 7-year-old who's got significant anxiety, driving defiance, you might recommend parent-child interactional therapy because we know that can work to help with compliance. It might be able to be used to help with anxiety, or there might be psychodynamic treatments or something related to, trauma-focused CBT if the kids have had trauma, something like that. But, using a psychosocial intervention or an online web-based therapy, if that's possible to ascertain. Level 2, if we have moderate or severe anxiety, like I said, we go back to level 1. Really, we could consider, if we want to say here, something about treating the parents, but I think really those are all just variations of therapy. I think the idea is we want to get them into cognitive behavioral therapy, and then we get them in with a therapist, and that therapist could decide how they want to implement therapy. So I don't know that I still don't think I would change the wording here. Level 2, if there's moderate or severe anxiety or an inadequate response to CBT alone, level 2A is initiate treatment with fluoxetine or sertraline, either alone or in combination with CBT. Level 2B is if the first SSRI trial with fluoxetine or sertraline is not effective, and or there are treatment limiting side effects, switch to the other SSRI not used in level 2A and initiate CBT if it wasn't already being used, or continue CBT if it's already being used. So no changes to that. Level 3 is if there's moderate to severe anxiety disorder or level 1 and 2 are not successful. So if they have failed fluoxetine and sertraline. 3A is that duloxetine alone or in combination with CBT can be used. And we caution people to monitor height, weight, blood pressure, pulse with duloxetine. This would be my addition here, as I would say to consider escitalopram alone or in combination with CBT. We could note for adolescents, because literally it was studied for the ages 12 to 17, that one newer study. And then 3C is to consider fluvoxamine alone or in combination with CBT. So that was already in the last version. So the study with fluvoxamine back in 2001 was a RUP study. There was 108 patients in that study. And so we had it here at level 3. Level 3A was duloxetine, level 3B was fluvoxamine. But I think that a lot of clinicians are much more comfortable using escitalopram than fluvoxamine. Escitalopram, I think, is a little bit better tolerated. It's usually once a day as opposed to the twice a day with fluvoxamine. And there is that one study, only an N of only 51 patients, but I think we could move escitalopram up from level 4. It was listed down below in level 4. I think it could come up to level 3. There's one study with fluvoxamine, one study with escitalopram. And level 4 is if levels 1, 2, and 3 are not successful, reassess diagnosis or refer to a specialist. And if level 3 is not successful, you could consider the remaining SSRIs, well, consider of the SSRIs, consider citalopram, or consider a different SNRI of venlafaxine, because in combination with CBT. So not recommended is paroxetine as first or second line because of concerns about increased adverse effects such as insomnia, behavioral activation, appetite changes. It's interesting, it says decreased appetite. I think usually we see weight gain with paroxetine, but we've seen more side effects with the paroxetine. And we also don't recommend benzodiazepines as the first line monotherapy for long-term treatment of childhood anxiety disorders. So no changes to that. We had a table here, and I don't really recommend any changes to the table. I'll let you kind of look at this for a minute. There's really no changes to this table from the last time we published it. So people can feel free to look at the doses and see if we have any recommendations, but this is how we had it before. The asterisks over here on the left side of the screen indicates that there's a placebo-controlled trial in children ages 6 to 17. So if we look at the next table, the only thing I would, next page of the table, the only thing I would change is putting an asterisk next to escitalopram, because since there is one study. So again, looking at doses based on age. And that's really it. I don't have, there really wasn't a lot of other information and not a lot of new information really about anxiety disorders, just a lot of variations on how CBT is delivered in person, online, you know, how much support families get, how, you know, how much support families are getting, and really not a whole lot that's new in the medication treatment realm. So just the only thing I would really recommend is just moving escitalopram up from level 4 to level 3 for the ages 6 to 17. So take a look at that and we'll discuss it.